Thanks,
Good
everybody.
morning.
Go ahead.
Unfortunately, I got the mirrored view here, but we'll be able to do this in reverse, I hope. So again, as Kevin said, total intravenous anesthesia has been around a long time, especially in Europe, the UK specifically, Canada. And the advantage of it is that for most of the time, the patient is spontaneously breathing. So that means you don't have to put a tube down their throat, an LMA or an endotracheal tube. There is monitored anesthesia care, there's MAC. So you can have some general anesthesia with the total intravenous anesthesia. But the ideal situation is you're looking at short duration procedures, 15 minutes to 2 hours is typical. It's big in children's hospitals now because we don't know if the patient's going to have a reaction to succinylcholine. That could trigger malignant hypothermia. So obviously in a pediatric patient, you might not have any history on that patient ever having general anesthesia before. So the two low-hanging fruits is spine, because in those procedures, they want some awareness, the ability to bring the patient back out to a little bit of awareness to make sure that they're not damaging certain nerves and certain portions of the brain when they're working with those patients. So the advantage and the specific characteristic of the drugs that you give are what we call short acting. So in designing this set, what we've done is we brought the input of the drugs down here on this trifurcated system. And so you have your main line, your main bore, and then you have two mini bores. You have a clear and then you have a green stripe. The clear one is a little bit larger inner diameter, and we have them marked. So on this one, we have it marked with a TIVA tag here, pump okay, meaning it's not going to alarm the pump, and it's 2 milliliters is the priming volume. So this is very helpful in that the doctor knows, how much propofol is in the line. And then the other one is slightly smaller at 0.85 milliliters. So, your less viscous drugs could go in that one. The two most popular drugs are Propofol, which is that milky white drug. Michael Jackson is familiar with Propofol. The milk of amnesia, and the other one is fentanyl or remifentanil, and there may be a third one added, which could be ketamine. And what we've done is we've placed a Y site above that, so you could add a third line of drug, which would make that the main bore and 3 drugs. That would be a 4-in-1, or typically here what we call a 3-in-1 administration. So the idea here is because these are short-acting drugs, they need to come in as low as reasonably possible to that patient's IV, so that it's a quick onset and a quick offset, and that it's not getting diluted in the main line or floating around there, and you have less predictability in those drugs' action. Quick on, quick off is really the key. So the other reason to have a TIVA set is in the UK, they have TIVA sets that are designed for this procedure. And the other thing that we're finding is a lot of institutions have said, guess what? We need to standardize this because everybody puts stopcocks and tubing and extension sets together differently. And again, you're going to have your ABC Medical syringe pump. You'll have a couple of these, 2 or 3 of these. So when you show the TIVA sets, show your pump. And that's a big thing. So your targets are going to be ambulatory surgery. They're going to use this in short procedures. They might use it in endoscopy. So while you're selling the palm mask, ask if they're giving Propofol, ask if they're giving TIVA. And again, those orthopedic surgery centers would be a key, and children's hospitals. We are working on listing about, somewhere around the top 6 or 7 procedures that this is popular for. So I'm going to stop here just to ask any questions.
Hey, Tom, could you show the cell sheet so you could actually show the IV set, kind of how it's laid out? Just lower it just a fraction. Yeah.
Yep.
So what you have is your primary IV set. Yeah. Go ahead, Tom.
So your primary IV set, and this one is showing the pediatric drip. So the other thing that is unique in this market is that we actually have the pediatric drip chamber. So if you're familiar, this is a 60 drop, and that has that needle in it, that blunt needle. So that's forming 60 small drops per milliliter. So that's more accurate. And then in the adult version, we have the HL TIVA 20 drops. So again, this is standardizing. So when they ask you, well, gee, Tom, we do a lot of pediatrics, you can say we're the only company with a 510K pediatric and adult set marketed for total intravenous anesthesia. So the competition is doctors are putting together their own product. Yes, so they are already doing IV anesthesia. They already are doing TIVA. And very much like you find, you've got 100 anesthesiologists. Somebody's going to be the regional anesthesia doc, the block jock. Somebody is going to be focused in on the one who's doing the most total intravenous anesthesia. So again, it's designed for TIVA. It's easy to use, promotes accurate drug delivery. We're introducing these drugs as close to the patient as reasonably possible. Quick onset, quick offset. We have pre-attached, color-coded so that they know which drug is going in the line. It reduces drug waste. Understand that Propofol is generic, so it shouldn't cost a whole lot. When it first came out, it was about $12 per milliliter. Now I think it's a few bucks for, a 50 ml vial. It's not terribly expensive, but people kind of have a hangover of thinking that Propofol is expensive. It actually has been bought by Fresenius Medical, who obviously is big in Europe. Packaging waste, they don't have to open up 3 packages. They just open up 1, and that speaks to the standardization. And considering intravenous techniques instead of volatile anesthesia gases, if you go online, you're going to find that the operating room in a hospital is anywhere from 4 to 10% of a hospital's greenhouse emissions. So doing a little bit here has a big impact on those volatile gases. Not to mention, a little fun fact, when a patient has inhalation anesthesia, desiflurane and sevoflurane, they only actually use 5% of the drug in that gas, and the rest is wasted and has to be scavenged, and currently is probably being inhaled by the staff. Questions?
Hey, Tom, how would you say it reduces waste, drug waste? Is it because we're using microbore or mini bore tubing?
Correct.
And since I said the word microbore, what is the difference between mini bore and microbore, and when is microbore used?
Well, microbore would be, less waste, but what it would do is it causes occlusion problems with the pump. So if you have something a little bit more viscous, like Propofol, it looks thicker, it's opaque. You would have, more resistance. So that's why the clear line is a little bit bigger at 2 mLs priming volume, and the one that would make sense to recommend for Propofol. And the other is just 0.8 of an ml in the green stripe tubing.
Is there ever an occasion where they only would use, would they still use our set and only use the clear tubing and not use the green stripe for some reason? Or are they always given multiple drugs?
For true TIVA, it's a combination of at least 2 drugs and maybe 3. What's getting popular is the addition of ketamine. So ketamine is a different drug that actually helps with recovery, less narcotic needed, better post-operative care, and you get actually a 6-month positive hangover of the ketamine infusion, and reduces anxiety and PTSD. So ketamine is getting to be very popular, but for true TIVA, it's probably always 2 or more drugs. In endoscopy, if you find somebody that is doing your colonoscopies and it's just the surgeon, they're giving Versed and maybe Demerol, and then you don't wake up as fast and you're clogging up the assembly line, they're getting paid around $1,300 for 15 minutes of work for colonoscopy in endoscopy. It pays to have an anesthesia provider, such as a CRNA or an anesthesiologist, give Propofol because of its quick onset, quick offset.
So Tom, would they use this with just regular syringes, or would they always want to be using a pump with this set?
You probably 90% of the time you'd use a pump. Could you do it manually? Yeah, you could do it manually. And that's the thing. I find that most people have pumps. The Medfusion pumps are out there. The Atlanta Biomedical Corporation, my experience with this pump is I might get a call once in 3 years and somebody says, hey, where do I get a new battery? And so in the surgery centers, this is a great combination to talk about. And it's kind of a highlighted product that will bring you into your other anesthesia products, showing the pump, talking about this with the palm mask in endoscopy. Because if you have an anesthesia provider like a CRNA in endoscopy, you're getting more throughput. You're paying for that anesthesia provider, but you're making more money in the long run. So that's a good place to go. I would say with the affordability of this pump, there's no reason not to use a syringe pump, but you could do it manually.
Yeah. And I can't say I've been in a lot of ORs recently, but I'm going to tell you, the ORs I've been in, I don't see them always setting up a pump. I don't know whether there's anybody out there that's been, and maybe that's because it's a different surgery that I'm in. But you're typically saying that if I'm going to do MAC anesthesia, which is monitored anesthesia care, I'm probably going to use TIVA, and I may use a pump or may not use a pump. But the point is that this set, if I'm not using a pump, this set will still help me.
Yeah. So if you find, people will prefer a pump, certainly. And of course, the 4100 has a nice little drug library in it. Your first 9 most used drugs come up here, and you've got 99 slots total. it really is the way to go. For a full TIVA sale would be at least 2 pumps with a pole clamp and your HL TIVA sets. It's just ideal.
Okay.
CRNAs are a big promoter. You'll find your CRNA in the smaller community hospitals and in the ambulatory surgery centers. They'll buy into this and help you sell it.
Well, one of the things I'll tell my people on the call here is that when you are administering by hand, you're basically giving small boluses, and the advantage of a pump is that you can set a rate that keeps that patient at the ideal state of consciousness or barely conscious. Whereas if they're using their hand and a regular syringe, they have to constantly be giving little boluses. So the syringe pump allows for a steady infusion, and they're able to get to a point of equilibrium, if you will, that a patient doesn't go too deep, and yet they're not too light from an anesthetic standpoint. Whereas when they're pushing syringes with their thumb, they're giving micro boluses, and as a result, what happens is the patient can go deep and then can get light again, then can go deep again and light again. So that's kind of the difference. Am I correct, Tom?
Yeah, the advantage is to bring them back out again, like in the spine surgeries, and they're doing a lot of spine in the outpatient setting. So they're definitely using it there for that reason. And then you generally don't have to intubate, but you could intubate with an LMA or an endotracheal tube. But again, this tends to be the sweet spot is 15 minutes to 2-hour procedures, or where they need to bring that patient out for that little bit of awareness, but they're not really understanding, that it's going on.
Okay, so my reps don't all have an ABC pump to carry around with them. So give me an example of an ideal sale that you've had, and maybe a department, whether it's a surgery center or a hospital. Like let's say I'm going to the hospital, I'm talking to an anesthesia tech or even the chief of anesthesia. I would pull this out and say, hey, what do you think of this? Or would I first ask, are you, I mean, everybody's doing some form of TIVA, so it seems kind of seems like a waste of time to ask, are you doing TIVA? Because isn't everybody doing some form of TIVA?
Well, they are, but your point is well taken. So my example is an orthopedic anesthesia group that led to the sale of the TIVA set first, because the doctor was trained in Israel and very familiar with TIVA, and he was looking for a TIVA set because over there, MediPlus is probably the market leader there in TIVA, along with Bebron and Fresenius outside the U.S. So he actually bought the TIVA set first. That then turned into selling 8 of the Atlanta Biomedicals. Then that anesthesia group was over in Wyomissing, PA. We sold 10 more pumps to them. And now 4 or 5 years later, they're going to buy 4 more Atlanta Biomedical pumps. And now they've been bought by a big hospital system. And I'm trying to backdoor that now that I'm an approved vendor, to backdoor from the surgery center into the hospital system.
Well, that sounds like a nice story.
Yeah, so the set led to the pump being purchased because they were going to do more TIVA. So the top two procedures are spine and children's hospitals. And then we've got a list of about a half a dozen procedures. Like there's carotids, where if you're a good surgeon, you can do a carotid bypass in 15 minutes, skin to skin. And so that's where TIVA is used. and a lot of other procedures where in a children's hospital, they may want them to go through an MRI, but they got to have them still. They'll use Propofol or TIVA depending on the procedure. You know, a lot of lumps and bumps for kids, and TIVA is preferred because you know that you don't want to fool with an experience with succinylcholine and malignant hypothermia.
Okay. So once again, a children's hospital call is a great start, but really any anesthesia contact you have, this would be a great thing to pull out and show them and maybe give them a sample of. Because what they're doing right now is they're taking a traditional gravity system that has basically some ports, and maybe they're needleless ports, but they're taking their syringes and putting it in up closer to where they are. And that's what you're saying is being diluted by saline solution.
Right. Usually a double gang stopcock and an extension set, and it kind of floats around, and it's not really designed for that. But you're right that everybody puts it together differently.
Okay. And cost-wise, this is going to be, I think our sell price is, I think our list sale price is $9.50. I think.
Correct. And if you, yeah, and if you remember, MediPlus was going to come to the market with $10 for an add-on.
Mm-hmm. What does that mean, an add-on? Just adding something
they would take. Yeah, they would take their they would take this section here as an add-on, which we might develop as well. There would be a lure lock here, and so just this little piece here, other companies would market for $10, where we can market the whole thing. Much more convenient, encourages standardization. So you find over in Europe, they're just selling this piece.
Okay. So let's go back to, I'm making a call on an anesthesia. Now, an anesthesia tech may not understand this as much as obviously a CRNA or an anesthesiologist. Am I correct?
But they'll know who does TIVA because they're doing the setups.
Okay. What you're saying is they're replacing setups in carts, constantly stocking them, right?
Right. So if you know Dr. Schitzenfarts wants to do TIVA, he knows he needs to pull this off the shelf. He pulls one package off the shelf rather than 3 or 4 or 5 pieces. That's an advantage. That's the sell to the anesthesia tech.
Okay. Is there ever a situation where you're using a mixture of Propofol and whatever other drugs along with anesthetic agents? You know, they're mixing throughout the case, they're doing a little bit of everything.
Yeah, and so the needleless port upstream is there for you. So plenty of access. We intend on moving the one that's just proximal to this set a little bit closer, so that if they put an extension line or they just want a hand bolus, it'll be closer to the TIVA set.
And closer to the patient then.
Correct.
Okay. All right, I've asked enough questions. Anybody else got to have some questions here?
Yeah, guys, we got about 5 minutes. So if you do have any questions, feel free to either throw them in the chat or ask as you will.
Well, I sure like that. I will make one comment about the ABC pump. It has a bolus button that anesthesia really likes, and so that when you're doing a case and if the surgeon says, hey, the patient's moving, they're able to hit a button really quick that says bolus, and they can either just touch it and touch it again and hold it, and then it will bolus that Propofol, for example, as long as you're holding the button. So that's kind of a nice feature. So it might be a nice 1-2 punch to talk about our pump and this TIVA set.
Yep, absolutely. It doesn't matter. The pump can come first and the TIVA set after. Actually, the TIVA set will prompt the need for more pumps.
Now, Emilio has sent me samples and I have been tardy at sending them out. So I will work it next week to send out samples to everyone so that you at least have a couple so that you can carry them around and show them and have it in your hand.
And if there are any accounts that are interested in formally evaluating it, please let us know and we can arrange for product to be brought in at no cost for them.
If we were going to use the phone and started to call some anesthesia departments, what would that be like?
You're basically asking, who's the TIVA guru? And
Okay.
they'll know, yeah, it's Dr. Ann Smith. She's the best. Call Dr.
So-
Ann Smith.
So we would be calling anesthesia and hopefully getting an anesthesia tech or somebody, a doctor or CRNA on the line, and we would ask them, do you have a clinician that uses a lot of TIVA or practices a lot of TIVA?
Right. And we did a seminar out on Long Island, and we ran into a lady who calls herself, she's a CRNA. She says, "Oh, I'm the TIVA queen."
Okay.
So find your TIVA prince and queen. I would go to the CRNA first because they're more likely to be forthcoming with the lay of the land, the politics, who you need to see to get a product in. I'd count on the CRNA to give you more information.
And I would tell everybody as our time's winding down here that the $950 price is very competitive and a great offering, but we have the ability to discount from that because I think the profit margin's pretty healthy at $950. So if we get an IDN that's interested, we'll definitely give them 5, 10, maybe even more off.
Yeah, it's a great product to pull through other products.
Okay, well, I know our time's running out. Emilio, do you have anything you want to say? And like I said, I'll get the samples out next week.
Yeah, if you guys have any questions, we're certainly, if you guys don't have any questions right now, but think of something as you're in the field, certainly Kevin will have our contact information so you can ask those questions directly to us and we can respond in a timely manner to get you the information you need to support you.
Tom, maybe I'll work with you, but Tim and I at my office will try to work on a combination brochure that shows the TIVA line along with our ABC pump, and maybe we can sell those together like that.